Good afternoon, everyone. I'd like to welcome you to the education component of the British Columbia College of Social Workers annual general meeting. I am very pleased to introduce Dr. Ellen Wiebe. She's a clinical professor at the Faculty of Medicine at UBC, and she will be speaking to us about the assisted death, so medical assistance in dying. And anybody who's followed the news lately will know that it certainly is a hot topic. So I take the opportunity to welcome Dr. Wiebe, and what we're going to do, we're live streaming the event, and because there's a delay in what happens in the room with what people hear in the internet land, we'll take questions at the end. So we'll just sort of carry on through. One of the staff of the college will read out the questions at the end, and we can rock and roll from there. So welcome Dr. Wiebe.
Thank you. Okay, can everybody hear me? Yeah. Good. So we're going to talk about assisted death and the practical parts of it, talking to patients. I know that we don't call them patients, but I do, so we're just going to have to put up with that. I've been a doctor for 40 years, and it's patients I talk to every day. Okay, so let's just quickly go over what happened in Canada with assisted death. In 94, it was Sue Rodriguez who asked for an assisted death. She was dying of ALS, and the judgment was 5-4 against her.
They said they could hear me. Okay. You were lying, weren't you? Okay, now you really can hear me? Good. Okay. So, at that time, Canada wasn't quite ready. Pretty close, but not quite ready. And, yes, I loved her quote, "Who owns my life?" And then the Carter case, we had Gloria Taylor also dying with ALS. She ended up dying a natural death, but this case was appealed to the Supreme Court. And that's what we're dealing with right now, is the Supreme Court decision. And in this decision, we have the rule that assistance is available to a competent person who clearly consents, who has a grievous and irremediable condition, whose suffering is intolerable. And being in the interim period between February 6th and June 6th, we have to get legal judge's approval for each case separately in this time period. What we expect in the federal law is something like this. There may be changes before June 6th, but the main changes that we're concerned about as clinicians are that it must be a grievous and irremediable condition, plus that natural death is expected in the foreseeable future. Competent adults, that it must not be primarily a psychiatric illness. 2 independent doctors, 15 days, 2 independent witnesses, other things that are easy to deal with. So I'm going to tell you stories about my patients. I have 20 of them who requested assisted death from me, and only one is completed. That's the one that was in the news. Also ALS, very severely disabled. So the conversation went on over 3 months. When she first contacted me, she got a hold of me through Netherlands, because I had found out in last fall that the palliative care physicians would not be providing assisted death. And I suddenly realized, that means that nobody's going to get one unless some providers step up to be ready to provide. And so my friend and I, both abortion providers, said, okay, well, we better find out how to do this. And so we contacted our colleagues in Oregon and in the Netherlands, and she had also been doing that, trying to find a doctor who would help her, and that's how we got together. So she qualified. Under the Carter rules, she was competent. She had a terrible medical condition. She clearly consented. Her family doctor was happy to write a letter to say that she qualified, but not to do it. And a judge awarded her the right. So she had to travel to Vancouver from Calgary. And she was very sure that it should have happened a while ago, which is why she didn't want to wait at all. And you can see the timing here. And with more details and some of the problems that we ran into, for example, I had to talk to the pharmacists in advance. They said fine. I went in Friday morning with my prescription and saying, okay, here's our first prescription. And they had a terrible day Friday, the two pharmacists, talking to their college, talking to the patient's lawyer, and they withdrew. And so I had to get secondary drugs in a way that I won't describe in detail, but were all legal and worked fine. And she was pronounced dead on Monday. So my colleague and I, Dr. Lily Mallison, found the experience quite profound. I've been in a lot of deaths because I'm a family doctor, and that's what we do. And so I had seen a lot, and none was quite like being with HS. She had a smile on her face at the end. She said she couldn't really talk, but she could, communicate. And she said, I love you to her husband. And she looked at me and smiled. She looked triumphant. She had worked so hard for this, and she got what she wanted. And that was something so new for me. I mean, I said I've been in a lot of deaths, and I had never seen that. She was in total control of her own death. I mean, she wasn't in control of this horrible disease that had taken everything she loved away from her. She was a very articulate psychologist. She loved to dance. She, was such an active, vibrant person, and this disease had taken all those things away from her, and she had so little power over anything, but she did have power over her own death, and it was really nice to be part of that. So what else are we doing and how do we look? We have one other patient that has authorization from the courts, and she has set her date. We have 4 more court cases pending. The affidavits are created, our lawyers are busy. The lawyers are not making the patients are paying a lot of money. The lawyers aren't making that much money because it's been a huge amount of work. They've been very cooperative with one another. This isn't something I'm used to from lawyers, but they're sharing all their documents with each other and helping each other get it done. A couple of them are working pro bono, but that still doesn't mean the patients aren't paying lots of money, because the patients still have to pay all the court costs and so on. So it's a crazy situation to be in the middle of this interim situation. So we are required to keep good documents, and patients must have witness consents, 2 independent witnesses. There needs to be 2 weeks. And these rules are coming from our College of Physicians and Surgeons, who have guidelines that we have to follow, as well as the law, of course. No, right now we're not dealing with the law. We're dealing with the Carter decision. But either that or the law as of June 6th. And so this is the kinds of documents that we have, that we put together. And then I'll talk to you a little bit about the actual experience, because some of you may be talking to patients about the actual details of what it might be like. And you're going to say, of course, you'll have to talk to the doctor about this, but this is what I know is the basis, which is 2-3 medications for IV, and that would be a sedative, which just helps them go to sleep very quickly, within a minute. A second sedative, which is much deeper, that causes a full coma, and then a neuromuscular blockade, which means that they stop breathing, and within a few minutes their heart stops. In Canada, we'll have the luxury of the choice between IV and oral, and the doctor doesn't have to be present for the oral, which means that it can be really a non-medical event. It can be in the patient's home. It can be, totally under the patient's control if he or she is able to swallow. If they've got a feeding tube, able to push it into the feeding tube. And the medications we would like to use are pentobarbital, which we don't have in Canada, and hope to get soon. But we have good drugs, and the reason we want pentobarbital is that it's faster. The vast majority are completed in 20 minutes, 99.9% or so within 1 hour. The drugs that we have will take some hours routinely, but as I talk to my patients about this, I just explain that that's what natural deaths are like. Almost everybody who dies naturally goes into a coma first and stays in coma for hours. I'm sure that you have been at deathbeds yourselves and your families, and you know this part. And so I just explain, and then they'll be ready for it. They'll be okay with the length of time that oral medications are going to take. So how do we help patients choose between? Well, first of all, of course, it's their choice, and that's so nice. They just need to know about the oral taking longer, that we have to use antiemetics so that they can keep it down, that if they're using opioids for their disease, that we're not going to be able to use that as our oral medication. They have to be able to swallow or have a feeding tube. And if they're vomiting, choking, have a bowel obstruction, oral isn't the way to go. With IV, the only issue would be IV access. There are people, especially the ones who've been sick for years and have blown every vein, that there may be a problem with IV access. So we don't have a lot of experience in Canada yet, so to find out what is likely to happen over the next years, we have to look at other countries. And in Oregon, about 1% of all deaths are assisted, but in Oregon, oral is the only allowed method. And that means that somebody with ALS has to arrange to die when they're still strong enough to do this. Some people lose their ability to swallow very early in the disease. They still have lots of other abilities. And some, would lose hand motion and yet still be able to do a lot of other things. And they would have to choose to die very early in the disease, perhaps earlier than they would really want to. Whereas in the Netherlands, Belgium, a lot of other places, it can be either oral or IV, and that means that when somebody, and it can be done by a physician, which means they can be a lot sicker, they can be a lot more disabled, and it allows people to, for example, just skip the last week of life, as opposed to having to skip the last 9 months of life, as you might have to do if you have only the oral available to you. There have been lots of people saying things like, oh, well, we just need better palliative care, and then people won't be asking. But that's not what's happened in the other countries. What's happened in the other countries is that the palliative care in the countries that have had assisted death the longest is the best. I mean, in the Netherlands, they don't have waiting lists for their palliative care. Everybody gets it. And they have such good home care facilities in the Netherlands, and that's built up over the decades that they've had assisted death. So it's not like the Dutch, killed off all their people that were taking up too much time and energy and money because they didn't have resources or anything like that. It was the exact opposite. When people start talking about end of life, generally, they're more likely to put resources into it and give really, really good palliative care. And that's what happened in Oregon, too. They have better palliative care than we have. They've had 2 decades of assisted death, and they have really good home hospice care, so that there are a lot more home deaths, assisted or not, there than they are here, because they have such good state-funded home hospice care in Oregon. So what we expect with assisted death in Canada is that our palliative care resources will go up, and we'll have better end-of-life care totally. And the other thing that we can learn from other jurisdictions is that there are many requests from people for assisted death who don't end up having an assisted death. They end up having a natural death. And in one study in the Netherlands, 10 times as many people discussed with their healthcare providers having an assisted death as actually had them. Now, if 3% had assisted deaths, you're talking about 30% of people before they die talk about an assisted death with their healthcare provider. Do you realize how many? That's mind-boggling, isn't it? That 30% will end up talking about this. And of course, you're in that position. You talk to people, and I talk to people. And so that's a big part of what I wanted to learn when I went to the Netherlands to learn this, was not just talking to the people who were going to be having the assisted death and being able to do a good job of assisted death, but to talk to the people who wanted to talk about assisted death, but would probably end up having a natural death, right? And so who are the people who actually choose to have an assisted death compared to the ones who choose not to in a place where, you're allowed to and you talk about it? So the studies are fascinating. The one thing I loved the best was to hear about the low level of spirituality, and I looked at that and thought, hey, that's me! So the people who are highly religious are more likely to believe that they should endure whatever they've been given to endure, and that they'll be rewarded in the afterlife. And who else chooses assisted death? Well, there's another, arguments that you hear from people who aren't very knowledgeable about how we'll be killing off all our poor, disadvantaged people with assisted death. That's not what happens in the places that have had assisted death for decades. Who are more likely to ask for it? People like us, professionals, educated, middle class and affluent. It's the people who are accustomed to being in control of their lives, not the vulnerable, who are not used to being in control of their lives. They aren't the ones who request it the most often. So it's interesting, there's this strong push to protect the vulnerable, which is good, but really, that's not who asks for assisted death. It isn't in the countries that have had it for so long. So it's not what we expect in Canada either. We expect people like psychologists to show up. So I want to talk even more about these conversations. I've been having a lot of them these last months, and I prepared myself for them for months before that by talking to providers about how they talk to their patients and what it was like to have these conversations. So the first parts are the same as the kinds of conversations around the end of life that you and I have been having for all our careers. We talk about the advance directives, the representation agreement. Do they need to go into residential care, or can we set up home care that will support them? And when do they decide to stop active treatment of their disease and go into just comfort care? These are the kinds of discussions that we all have with our end-of-life patients. And these kind of discussions are much the same. And then you have some questions you ask your patient at that stage. You're getting close to the end of your life. What is the most important to you now? And what do you want to get done before you die or before you become more disabled and can't do certain things? And for many people, it will be like this woman. She wants to, one of my patients just told me, okay, I'm going to see my granddaughter graduate from high school, and then I'm going to, have a family trip with all my kids and on a cruise. He's pretty disabled, but he could manage a cruise, and then I'll be ready. And, this one, I love that my grandchildren are all far away from me, so it's Skype. And I look at this picture and think, yes, there comes this time when I need to touch my grandkids. It's not good enough to just see them on Skype. And I see her there, she's touching her grandkid. And so, I've got to do something particular. And we all know that something like ALS, which comes up frequently in the discussion of assisted death, because it's one of those horrible, horrible diseases that takes active, healthy people and leaves their brains completely intact while destroying their bodies. And we know that there's the exception, like Steve Hawking, whose disease stopped. He became more and more and more disabled, and then the disease stopped, and he's alive through old age, which he certainly didn't expect when he was diagnosed. But the vast majority live only between 2 and 4 years. And when I'm talking to some of my ALS patients now, we talk about how much is too much. There's both the disability that they currently have and the fear of the next part of the disability. And that's the pain they have. The ALS patients have lots of muscle pain as their muscles, completely disintegrate. And then there's the fear of the pain as the disease is progressing. And so, one of HS was extremely disabled. She had movement in one thumb and one finger and a little bit in her facial muscles, and that was about it. And one of my ALS patients is still walking. Not very well. She uses a walker and she's a wheelchair, but she can actually still walk a little bit, and yet she wants her death now. Why? Because she's at the point that with the highest level of home care, she has to go into an extended care facility within a short period of time, and she says that's it. That's too much for her. And don't blame her. I spent 2 afternoons a week for 4 years with my mother in extended care, and every time I was there watching the people around me as well as watching my mother, I would say, I don't want to go here. And that's how much, is too much for this patient. She says, I am not going into extended care. And she has a feeding tube, she's got BiPAP, the positive pressure to help her breathe. She's got absolutely everything that can be done at home for her, and she knows that where the next step is, and she says she's not going there. So we talk about the good death with our patients. What does a good death look like for you? And there's a whole lot of things that everybody agrees on. Everybody agrees that they don't want to be in pain. And usually good palliative care can get rid of pain. Maybe 5% of the time. Leaving 5% that they don't. We all want a peaceful death for ourselves and for our loved ones. And peaceful means what? It means no agitation and anxiety and the fears and so on. But we see sometimes at the end of death, at the end of life, I mean. And people want to die in a good place, and that's different for different people. I thought when I was talking to one couple who are planning her assisted death as soon as the law is in place, that is, they're not going to court. And they told me that they were, one of those couples who didn't go out a lot and didn't have a lot of people in. They were this sort of, they and their dog were enough, pretty much. So I assumed, of course, that she'd want to die at home. And she said, absolutely no way was she going to die at home, because she knew that would mean that the home would be associated with her death in a way that she wasn't going to do. And so they had to find another place. And most people, when you ask them where they would like to die, they would like to die at home. But you can see that wouldn't be right for some people, right? Even though this woman also has no intention of going into extended care, and she is very close to needing that, she had to choose another place. And another of my patients is in a care home. He was a professional athlete and, not pleased with being in a care home, especially since he's in his 40s and everybody else in the care home are in their 90s. And our health authority was really freaked out because this was going to be their first one in a care home, and they had to get all the policies and procedures together and had to have high-level meetings with everybody. But my patient said, pretty much anywhere but here. And he hated the care home. And that was not where he was going to spend his last minutes of life. He actually asked for a rather inappropriate place and has been talked out of it because there are some rather inappropriate places to die and have the funeral home arrive for your body. And then we ask people who you want to have with you. And I have one family that's really struggling right now. There's no question about her having her assisted death, and that she wants her husband with her, and he wants to be with her. All that's good. But it's the adult children. They are uncomfortable with it, and there's discussion about whether they should be there on the day. And, this will go on probably. So you can imagine how the discussions go on all of these points of choosing. So we're used to those kinds of discussions in natural deaths. But the one part of the discussion we've never been used to before is this part about it being under your control. Exactly where, exactly when. It used to be just hospital or home kind of choices, but now it's many other choices. And so exactly, when, which day, and people are doing things like, I want to do it right after my birthday. Is that really the right thing to go? I mean, we want to honor our patients' wishes, and it's very special that they can make choices like that. But then you don't want them, it should be around some other things, maybe not. It's an interesting issue about exactly when, exactly where, exactly who, and then how. And I explained to you that basically the choices are oral or IV, and that the differences are that the doctor has to be there to push the fluid into the vein, or oral, where you would have it a longer process, more like a natural death, but though it doesn't have to be with the doctor present. And as I said earlier, the requests for assisted death are much, much greater than the actual assisted death. And so I'm getting, such interesting conversations with people about this. For example, two of my patients, one with a head and neck cancer and the other with ALS, were at the point where they needed feeding tubes. They were losing weight, their nutrition was falling, eating, swallowing was a big problem, and both of them had refused. They'd said, that's it, that's my line, I'm not having a feeding tube. And when I explained to them what the process of an assisted death was like, and that the medication could be put into the feeding tube, they both changed their minds and decided to get a feeding tube, which means that their nutrition is going to come up, their energy level is going to come up, they're going to be palliated in a really good way. I mean, they're going to feel better. But because they then had the knowledge that the medications could be given by the feeding tube, and that would allow them to be, both of them wanted to be at home with their loved ones, without a doctor present, without having to travel, because one of them lived in a small town which wasn't going to, they were not going to be able to find a provider in that small town, so they were going to have to travel to Vancouver. So they weren't going to have to travel, they were going to be able to do it at home, they were going to be able to do this. He was so happy. I mean, he was just so happy when he realized that, oh, I'm going to get my feeding tube, I'm going to see if I got enough energy to go golfing. He was the one with the head and neck cancer who was, getting very disabled in terms of his throat and pain and so on. But his legs were working in his arms, and he thought maybe he'd get another golf game in. It was such a delight to be able to offer him something that meant something to him that his other physicians who had offered a feeding tube, which he rejected, but now that he knew he could have an assisted death, yes, then he could go, now he can last longer. And as we all know, when people have end-stage cancer like he's got, all of a sudden he may get a pneumonia, a blood clot, heart attack, stroke, and be gone. And one of my patients who requested an assisted death, he was in assisted living, and he was at the point where he was going to have to move to extended care. And he just lost the last bit of function that really mattered to him, and he said, that's it. If I can't do anything better than this, I want an assisted death. And he was dead in 5 days of a natural death. I mean, there was certainly no time for him to get through a court process and for me to help him. And I wonder, our new rules will require a 15-day cooling off period unless there's a good reason not to. There's exceptions. So if somebody has got a sudden deterioration in their condition, it is possible that we could do it very quickly after June 6th, but most of the time we're expected to have a 15-day between the first request and the second request to make sure that it's an enduring request. So chances are I would not have been able to help that man anyway. He was heading down that road. He thought it was just sort of normal kind of disintegration, and then just down he went. So we're going to be doing a lot of talking about this in the next years, and what happens is that assisted death can provide, it's like an emotional insurance policy where you can say to yourself, if it ever gets too much for me, if I really can't stand it anymore, I have an exit, I have a way out. And that means that you can face more. And when a patient knows that their request will be respected at the time, they don't have to do it. They can just know that they still have some control. Even the ones who don't exercise this control, they have more control now. And one researcher who did some wonderful qualitative work in the Netherlands talked about social death, and what she meant was that very often towards the end of life, people stop having real conversations. I've certainly watched that a number of times. So she called it social death, where they're no longer engaged, interacting. They go into themselves. And what happens with assisted death is that you can be what she noticed in assisted death was that people would remain engaged, still involved in their close relationships with their loved ones right up to the very last minute. You know, they wouldn't care so much about who was prime minister, but they would care about what was going on in their immediate circle and their own life, and so still be engaged and if not wanting to talk about anything else, talking about their own death. And that they know that if it ever becomes really unbearable, they can do it, and so that's how assisted death is really already improving the quality at the end of life for people here, and will certainly do a lot in the future, I believe, as people are able to talk about this more and improve all of end-of-life care, because we're starting to really talk about this more. And now it's time for questions. Yes, would you like to moderate?
There's a microphone, just so the people online will be able to hear. If you could just go to the mic, that would be fabulous. Thank you.
Hi, thank you. First of all, that was a wonderful presentation. My name is Megan. I'm the social worker in the ALS clinic at GF Strong. So I'm having this conversation on a daily basis. And I have a lot of patients come to me very concerned about accessibility. They're astute and they know that just because it passes doesn't mean they're going to be able to have a provider carry it out. So I've actually used your name. Good. And it seems to give people a lot of reassurance, but I'm just wondering if there are other doctors coming forward, if you anticipate wait times. This is the information that patients are really asking me for. How are they going to access this?
Okay, so we anticipate no wait times. My colleague Rowie and I are committed to this, and I'm working really hard on getting other doctors. At this point, that's it for this area. We have some colleagues on the island who will be helping. So again, GF Strong works, the ALS clinic is also on the island because one of my patients is over there. And so we will work on this, but access is everything to me. I mean, that's why I did this. This has been so much a part of my life for abortion. You know, there's this legal right to have an abortion, but you can't have one unless you've got a provider. And wait lists are bad. And so I have worked very hard for access to abortion, and I'm working very hard for access for assisted death.
Okay, good.
Any other questions?
Yeah, thanks so much. My question is, what are the control mechanism like during the process? If the medicine reacts or something like doesn't work for?
Sorry, I didn't understand.
Like during the process, assisted death, if the medicine doesn't work on it, do you have like the backup plan or?
Okay, so we don't have to invent the wheel here. We have physicians, colleagues who've been doing this for decades, and we know now what to use so that there are no mistakes. The only errors that have come in Oregon have been situations where patients did not follow the directions and were at home alone, and didn't get the medication down quickly enough and didn't keep it down because they didn't follow directions. But nobody else is having problems anymore. That is certainly possible if you don't have decades of collegial experience. So I have no concerns that we'll have that problem.
I just want to thank you so much for doing this work. It's obviously just a really pressing area for so many people. I'm a social worker as well as an activist, and I've been involved in this area. Right now, this hasn't passed, and what they've presented falls short, according to a lot of people. So I'm just wondering if you could give some of us that are interested in doing advocacy on this issue some recommendations about things that we can do to try to make a difference. One obvious one, of course, is to contact our MPs, but I'm wondering if you could give any other suggestions you think might be helpful for us to put some pressure, because there was a parliamentary committee. They did not go forward with the recommendations, and this very much falls short, especially around the area of advanced directives for dementia, and that's one of my biggest areas of concern. Thanks so much.
So I'm not really an activist. I mean, I'm working really hard on my part, which is taking care of patients and helping other doctors take care of patients. That's my issue, and let other people do the advocacy. So I would just say contact Dying with Dignity. They are our advocacy organization for Canada, and they have all that kind of stuff, like how to talk to your MPs and stuff.
Hi, my name is Michelle Sutherland. I'm a social worker, but I'm also a manager at 2 hospices in Vancouver. And I guess two questions. One, what do you think is the request for assisted death sort of tie into the lack of good palliative care? Is that, do you see, because of lack of palliative care? And then also, what, if any, role does hospice play in that?
Good points. So what I expect will happen in Canada is what happened in the other countries that have assisted death for a long time, and that is that at first palliative care physicians and facilities were not involved. It was people who were members of Dying with Dignity or this similar organization. So, for example, in Oregon, they've had their law for, I think it's 19 years now, and at the beginning, 100% of prescriptions were written by Compassion and Choices physicians, who is the equivalent of Dying with Dignity. Now, it's 95% hospice physicians, and these are almost all in the home care. So almost all the organ assisted deaths are occurring at home, and the physicians and nurses involved are the ones connected to hospice. And that's a huge change. But it took 19 years. It wasn't quick. So I'm thinking that that's probably going to happen in Canada very, very slowly, that it will be integrated into really good hospice care at home, which is what Oregon has now. I'm hoping that that's what's going to happen. Right now, none of the hospices that I know of are going to allow deaths to occur there unless they're forced to. I was just at a meeting at Vancouver Coastal today, and there was this usual discussion about not on my ward. And where was it going to happen in the hospital, if it was going to happen in the hospital, hiding away in some little family room. Lots of sections have a little family room where you go for hard things. At this point, that's not working. What I'm expecting is that, just as I was saying, that resources for palliative care are going to increase in the next while, because everybody's going to be talking about end of life more than they were before, and that we can expect more palliative care beds, more home care and hospice, which is where more of the money ought to go. I'd love other comments on this. Anybody else working in hospice?
I don't.
To the microphone.
Okay, so I hate public speaking, but I'm a new social work. I just graduated in February, still looking for work. I've had 22 years of hospital experience as a unit clerk. I hear sometimes with people say, I don't want to do hospice or palliative care because they're resisting death, and that means death to them. That's kind of their last place before death. So do you think, I know you said not over my dead body, but do you see the hospice and the palliative teams thinking that will be accommodated? Because if people want that control, it's like, would it be, I say that you're either going to have hospice or palliative or no assisted death, or that's going to be the transition that you're going to have that choice to at some point in the future to get hospice and palliative care and then the assisted death. So there's that empowerment, and people can be comfortable and still pick the date or time when they want to die.
So, of the patients I've been meeting and talking to just in the last few months, most of them have done a lot of palliative and treatment care. And so, because, you know, they're the kind of people who like to have control in their lives, I think. So they ask for and receive services. So most of them have palliative care physicians, even the ones with ALS, which, you know, neuromuscular diseases are less likely to see a palliative care physician than a cancer patient. But my ALS patients, most of them have seen palliative care, and the one who refused her feeding tube and now decided to get it is now going to see a palliative care physician. So they need to have their symptoms controlled, and it's part of my job as an assisted death provider, who is not a palliative care provider, to know about palliative care. In January, I took a 5-day course, and I mean, I'd done lots of palliative care in my career, but I took another 5-day course on palliative care to make sure that I knew the latest stuff that was available, and so that when my patients might say something like, I just, you know, can't stand this pain, and I find out what I take. No, the painkillers give me too many side effects. I say, you know, you need somebody who could really work that through, because we've got a lot of painkillers and a lot of ways of getting around these things. So if you're in a lot of pain and you're having too many side effects from your painkillers, let's get a palliative care doc in here and work on that. Even if it's for the 2 weeks we wait for the assisted death. Like if we need the 2 requests 2 weeks apart. So I think it's got to be together, and I certainly have been talking to palliative care physicians quite a lot in the last 4 or 5 months, and you know, none of them want to do it, but they are working with us on specific patients. No problem.
I have one more question.
Yeah.
I know with doing some reading and research, they with people that have lifelong injuries or the ALS, I know a lot of them will say, like, I want to die, and sometimes it takes up to 2 years to kind of not get, I say, get over that, or kind of accept that this is now their illness and they don't want to die. Do you feel like, I know this is playing devil's advocate with the assisted death, it might be a gateway for people wanting to die earlier than they might change their mind? I'm just kind of thinking about what I've read. It takes time to do it, but then if it's available, people may opt for that sooner than what they're maybe ready for.
Yeah, and this will be difficult because I come from the position of human rights, so it's a basic human right to have the control over your own death. And so, but do I have to do it is, you know, a question, because suicide is still legal. I mean, you can commit suicide without having a doctor help you. One of the issues with the Sue Rodriguez case was that she was so disabled that she could not commit suicide. She didn't have the physical strength to commit suicide. And so she couldn't have that right unless somebody helped her, which at that point was a criminal act. So the issue of somebody who So, for example, I've had a request from somebody that I've refused who is young and has chronic pain. Well, we all know chronic pain people. They suffer terribly. And he's had many, many tries at treatment of this chronic pain. But he's young, strong, healthy. Can I do it? No, I can't. And maybe somebody else would be able to say, that they really had that. Luckily, the law won't let me, so it's easy for me to say no to him. So then, for example, if you see a brand new quadriplegic and a young, healthy person who is a brand new quadriplegic, and he says, I'm not living like this, I want to die, which a lot of them say. But we know, because we've got experience and knowledge, that actually people before they become quadriplegic and after they become quadriplegic are usually just as happy or just as sad. They've done lots of studies on this. A year after you've been through GF Strong, you've done all your rehab. If you were a happy person before, chances are you're going to be a happy person afterwards, and vice versa. And we know that. So, are we going to let that person? Well, at this point, we're not allowed to because of the C14. But if we were, could we say, no, you've got to wait a whole year. You've got to go through rehab and then decide whether you find life worth living or not. One of the wonderfully experienced physicians in the Netherlands said to me, I have to personally feel that it's right. And I thought, what a paternalistic person. I mean, after all, people have a basic human right to control their lives, and why is he saying that he personally? And then I met this young man with chronic pain. And I thought, oh, that's what he was talking about. I have to actually feel right about it too.
Thank you so much, and I'm sorry I missed the first part. Just traveling or trying to find parking, but I really wish I had not missed the first part.
It's been recorded, I believe.
Hi, I'm a recently graduated social worker who did a practicum at a hospice unit in Thunder Bay, Ontario. Before this law, before the ruling, and we had a patient on the unit with ALS, and he wanted to have a conversation about an assisted death. He's a very educated man, and his wife, who was quite religious, was completely against the idea. He ended up having a natural death, but the conversation went back and forth a number of times, and I just wondered what you would say about sort of talking to
the family. Oh, it's such an interesting thing. So one of our consultations, we went into the home, my colleague and I, and there was the woman, our patient, and her husband, and her brother, and her son, and her mother. And it was the brother who was against assisted death. And, I mean, they all loved her. They all were distressed at her terrible situation. The brother was crying, but this felt it was so wrong to be there. Now, the most important people in her life, namely her husband and her son, were totally supportive. And I know that she's going ahead and it will be fine. But her brother needed to deal with it. I mean, you remember, and this is what I learned from somebody else, and I've been saying to these people, remember that you'll be gone and he'll be left. And so let's try to help him through this. And when it comes to the important people in your life, namely your spouse, that's been a really interesting issue too. I mean, I was with one couple where, she had a smile on her face when, we were planning the date and the time and so on. I've got to meet people with diseases that I never knew existed, and I, put them on my list of the ones I really, really, really don't want. Couldn't believe what she has had to suffer. And I asked her husband, and he says, with my head, I agree with her, but in my heart. And so he's totally supportive. He will be there for her all the way. But it was, again, she was smiling, no tears, and he had tears running down his face because he was the one who was going to be left behind. She was going to be gone, and he was going to have to live the rest of his life without her, and this was what they were dealing with. So again, one of the Netherlands physicians said, it's really important to get the family in, and if there's been some rupture between one family member or another, to try to heal that rupture and get it before you do this. And I thought, more paternalism here. There are people that certain people in their family don't want to see, and if they don't want to see them before they die, that's just fine with me. But now actually that I'm again seeing all these family members struggling with this request, then I see that too, and I think, okay, remember, he's going to be gone, but she's going to be left there. She's going to have to live with this, and so let's try to help her.
Hi, my name is Zalka Korak, and I work for Vancouver Coastal Health. And speaking of families, I'm just wondering, have there been any studies or follow-up on family as you're speaking about this brother, like follow-up to see what the longer term
Okay, so I haven't
effect is?
seen a large quantitative study, but I've seen some excellent qualitative studies where the major issue is the discussion about how peaceful their deaths were and how the loved one got what they wanted, and that's what they talk about afterwards, which is good. I mean, they're coming from a good place.
So what I was actually thinking is like the family members that had an issue with it, how they are dealing with this, like post, say, 6 months later, a year later, 2 years later, like how is the brother managing? Is he,
he's going to come around.
Well, I mean, that's what I'm wondering.
He obviously loves his sister a lot, and there's a lot of family support in that family, and I see them just talking to him, and he's going to come around to her point of view. She used to run a company, and she was really organizing this meeting with us that day. It was a delight to see. She was sort of on her throne, reclining, because she had very little strength. But, yes.
Well, I don't want to interrupt the flow. I just wanted to thank you, Dr. Weeba. My name is Curtis Magnus, and I'm the chair of the College of Social Workers, and want to thank you on behalf of the college for your willingness to come and share your wisdom with registrants. It's obvious by the turnout they didn't come to hear the AGM necessarily reports, but instead to hear what you've been doing and to encourage you in that work. I did want to ask one question, because early this morning the Canadian Association of Social Workers released, I'm not sure if it was a press release, but it came to all social work members, and it really was encouraging social work as a profession to really lobby, I guess, government to have social workers included in the list of care providers who would be exempt from prosecution. alongside physicians and pharmacists and nurses. And I don't know if you would be willing to comment on that, or...
So the only issue there would be around the criminal provision on, how do they say it, aiding and abetting suicide, right? And so you know damn well that nobody's going to criminally prosecute you for discussing your client's wishes in a professional way, as you will do. But obviously, some social workers might be concerned that if they did discuss somebody's plans for an assisted death, that they might be seen to, in some way, have aided and abetted the suicide. So, yes, I mean, counselors in general, shouldn't they? I love the wording at one point, which was just anyone helping somebody, and it should be, wouldn't it be nice if it was just something like that? And that would include family members, because the way the original law was set was that only doctors and nurses, pharmacists would be exempt, and that no family member would be allowed to even hold the cup up to the lips, much less push the syringe into the feeding tube. And that would interfere with someone's right to be able to have a home death if they didn't have the strength to do those things themselves, right? And so the family members should be exempt from helping in a medically assisted death. So it would be nice if that was part of it. And I did see the wording that actually did that, but I can't remember now exactly where it is and how, and whether we'll get it. But that would be what I would like to see.
Right. Because I think one of the worries that for social workers is, as you've heard, social workers are often dealing with family dynamics around issues surrounding this. And at the college, the kinds of complaints we get related to end-of-life care generally are from sort of disgruntled family members about a social worker doing what was legally and ethically required to do their job. And so I think there might be some solace for social workers if, in fact, they were considered allied.
Yeah.
Anyway, if John may be giving me a look, but if there are other questions for Dr. Weed, by all means, please.
And there's no questions online? Any final words, Dr. Weed?
No, I'm just glad that we can all work together to improve the quality of the end of life.
Thank you very much, and on behalf of the college, we have a token of appreciation for you.
Thank you. Do I get to open it?
Oh, sure.
Oh, isn't that beautiful? Thank you.